Okay, so let's initiate the first speaker, and this is Dr. Paul Rosen. Dr. Paul Rosen maintains a full-time private practice in both Yardley, Pennsylvania and New York City, New York, limited to periodontics, surgical implant placements and regenerative therapy. He also has appointments as clinical professor of periodontics at the University of Maryland Dental School and also adjunct professor at James Cook University in Cairns, Australia. Dr. Rosen is a diplomat of the American Board of Periodontology and has served as an examiner as well. He reviews for and serves on the editorial boards for a number of dental journals. He has authored and co-authored a number of articles on periodontal regeneration, dental implants and laser-assisted treatments, and has lectured both nationally and internationally on these subjects. Dr. Rosen is also honored to have been named the 2015 recipient of the American Academy of Periodontology's prestigious Master Clinician Award and has also received the Northeastern Society of Periodontists Isidor Hirschfeld Award for Clinical Excellence. Please welcome him on stage with a warm round of applause. Welcome.
Guten Morgen. Ein Vergnügen to be here today. Welcome to the Osstell session. I voted for no for the champagne afterwards because I preferred mine now. Hopefully I will keep you awake and enhance your experience at this morning's session. So, I have only 30 minutes. I wanted to thank Osstell for making this. This is their 10th year anniversary, but for me, this is my 31st year anniversary of returning to, or 41st year anniversary of returning to Vienna in 1979 as a college student. I studied here, and in 2018, I finally returned. So it's been a long time between the parades, and I thank Osstell for making this possible. I want to pose a question, and we're going to check out how well the system works. You should start the timer, by the way. Otherwise, I'll be here for an hour and a half, and nobody else will get any time, right? So, question I throw out to you. How are you determining when to load your dental implants? And if we could put the questions up. Get an idea? Nobody knows how to determine when to load them? Okay, we're starting to get some returns. You know, your participation in the champagne tasting afterwards is dependent upon your answering, and only 10 people. 12, okay. Hopefully we'll wake a few more of you up. Give it about another 30 to 40 seconds. So, it seems that most of you are relying upon either the surgeon or tapping the implant or the reverse torque tests. So, I'm going to push forward here and let's explore that a little bit. For some of you, we didn't put this up, but maybe some of you are just simply guessing. And if you are, you're doing both your patients and yourself a great disservice. But looking back at that question, if you're relying on the surgeon, how is he or she determining that? Is it simple intuition? Is it they take a guess? Are they going based upon literature of the company? Well, if it's the company, that doesn't necessarily account for immediate placement and loading of implants, grafting of the sites, and variability of the patients themselves. These are usually run on pristine sites. If it's based on past data, machine surface implants and roughened surface implants are two different animals as to how fast they integrate and whether they integrate. And last but not least, if you believe in the reverse torque test, you're probably doing more disservice to the patient because it's a rather destructive and crude way of doing it. We have entered today an era of what we call personalized medicine. At least in the United States, this is the big buzzwords that are being used. And in order to better meet the needs and challenges of our patients, what we need to do is we need to take a personalized look at their care. And I'm going to give you 4 real-world scenarios to consider, and maybe some of you encounter them as well, as to why you need to be using the Osstell system to determine when you're going to provisionalize or load your dental implants. First, there's considerations that we have to make to an aging population. Maybe none of you out there, but I'm seeing more people in their 80s and 90s come in that lose a tooth or teeth and want to have replacements. There's compromises to healing that are applied to our patients every day, such as diabetes. Back in the 1990s with the consensus conferences, we felt diabetes to be a risk factor. We're going to talk a little bit about it. Today, the most recent consensus conference questions its risk for peri-implantitis because there's no supportive data for that. Nevertheless, it does have some impact on wound healing. There's problematic situations, something that I just recently wrote an article about that will be appearing this coming month in the Compendium of Dentistry called the bungee dip. And last but not least, maybe none of you out in Europe, but in the United States certainly, we seem to be specialists in patients who have extenuating circumstances. And I will present to you a case of an extenuating circumstance patient because all of our patients feel that they're special and they have certain needs. So how about that aging population patient, the one who's aged 80 or better? Many people come into my practice and ask me, at over 70, should I really be doing this? I mean, is the implant really going to last? Is this a wise idea? And, I don't have a lot of time left on this earth, Dr. Rosen. How long am I really going to need to wait? They don't want to wait because they don't think they have the time left. The problem is you juxtapose that with a famous saying by a famous basketball coach in the United States named John Wooden. And John Wooden best put it, if you haven't got the time to do it right, how will you have the time to do it over? So you have these 2 forces tugging at you. 1, the patient has a rush to get done, but 2, you want to proceed with caution. So here's a patient who comes into you. She's 85 years of age, low lip line. She has a lateral incisor that's going to be lost. And the question is, she has a non-contributory medical history. Her concern is decay that's dooming this tooth. And the confounding factor that I have is that this patient under no circumstance wants any radiographs exposed during the process, as few as is humanly possible. And oh yeah, by the way, she doesn't want to wear a transitional partial denture and she doesn't want to be edentulous. So what am I going to do? So the tooth is extracted atraumatically. That's what we always say as surgeons. Everything's atraumatic. The difference between atraumatic and traumatic is if you're the patient, it was traumatic. If you're the surgeon, it's always atraumatic. So I removed the tooth atraumatically. I placed a dental implant immediately, and I observed the insertion torque to be 26 Newton centimeters, but the ISQ was 78. 78 buccal palatally, 78 mesiodistally. And the question is, what do? Do you put a healing abutment on? Do you provisionalize? Do you bury the implant? Well, this patient wants to go forward with provisionalization. Normally, 26, I'd be on the fence, but with a 78 ISQ, I felt very comfortable because this patient, I feel, is compliant. She's been in my practice for 30 years. I know that she will listen to directions. So the decision was made to provisionalize her. And this is how it looked on the day of placement. Fortunately, she was willing to let me expose this one radiograph. So in the subsequent healing, what I was going to do was to use the Osstell machine, and this is how she looked on the day of placement. And at 4 months, you can see plaque control is not ideal with this patient. We repeated the ISQ values, and you can see, yes, we've had a drop from initial, but this has been very, very stable overall. She has very high stability readings at 16 weeks, and I feel that at this point at 4 months that we can go forward and complete her. The problem I find many times with patients is that with these second and third generation implants, bone healing proceeds quicker than soft tissue healing. And this is the completed case. Now, this was at 4 months, and I can tell you she's now at 2 years, and we are still at this steady state of health for this implant. So what I've been able to do with Osstell is I've been able to allow the machine to guide me in my clinical decision making. The real benefit with Osstell is that the machine becomes the bad guy. Sometimes I don't proceed with provisionalization or further treatment because the values are low. No longer is it Dr. Rosen is the bad guy. Instead, the machine is telling me that the patient heals slowly, so I put the onus back on them. How about patients with diabetes? The literature is kind of schizophrenic on this end. On one hand, my dear colleague Tom Oates, who's my boss down at the University of Maryland, has shown in reviews that appropriate accommodations should be made, according to his words, for implant integration. If you go back to the studies at San Antonio, Texas, by Scott Dowell and others, patients with poorly controlled diabetes can heal and can achieve osseointegration, but it may take longer. And the problem is you talk to a lot of diabetic patients and they always tell you, oh yes, I'm well controlled. And then you ask them what's their A1C values, and then they say they're 8.1. 8.1. That's not well controlled. So you're constantly fighting this battle of how long will it take for them to heal, and Osstell is a great way to determine beyond just glycemic control where they're at with their bone healing. With respect to developing peri-implantitis, the World Classification Workshop recently determined that diabetes is inconclusive for being a prerequisite to developing peri-implantitis. So we have this battling situation. So I like to use the Osstell for patients with a compromise in terms of their medical status, and Dr. Kuchler is going to go into that in much better detail than I can possibly give you in about 7.5 minutes here. So this is a patient who is a diabetic, well controlled, 5.9 in his glycemic control with his hemoglobin A1C. The tooth, which is the lower right first premolar, is deemed hopeless due to historic caries and failed endodontics. So it was extracted, and the site was immediately implanted. Great insertion torque and excellent stability. ISQ of 70 in the buccal lingual direction, 69 mesiodistally. So a healing abutment was applied, and I used a combination here of a bovine-derived xenograft mixed with collagen, and that was hydrated with platelet-derived growth factor, recombinant platelet-derived growth factor, and I have to profess this is an off-label use, but nonetheless, I could give you good evidence as to why I do that. And on top of that, I happen to use a collagen membrane. Site was sutured. You can see how it looks at 10 days post-op. The soft tissue wound healing is excellent in this patient. And at 30 days, it is still consistent with someone who would seem to be fairly well controlled in their glycemic observations. At 12 weeks, I decided to get an RFA reading. If you look, we're far better than where we began. So some people would just capriciously say all diabetics need to heal for 6 months. Not this individual. This individual might have been good at 8 weeks. I arbitrarily decided to look at 12. I felt that the soft tissue was mature enough and that if we wished to proceed to completion, we could, which is exactly what we did. And this was the patient at 5 months, though he was completed somewhere at around 4 months. So, another scenario that I'd like to talk about is something that I refer to as the bungee dip. What is the bungee dip? Well, for the Australians, they'll probably appreciate this better than the rest of us because bungee jumping is far more prevalent there than probably anywhere else in the world. But we all know about the dip that occurs in implant wound healing, where you go from initial primary mechanical stability, and that diminishes where biologic stability increases. And somewhere around 3 to 4 weeks is where that dip occurs, and depending upon how active the surface is, it may be in sooner, and it may be later, and depending upon the patient, that dip may occur sooner, and it may occur later. The problem is there is a very small subset of patients that I see who have this profound dip. It doesn't go down 5 or 7 units. It might go down 20. It might go down 30 units in terms of RFA. And it's scary, quite frankly, sometimes. And there's no rhyme or reason as to why it occurs. Here's a patient where I first observed this quite a number of years ago. This happens to be a 74-year-old teacher who is retired, who comes to me with her tooth number 2-1, her maxillary left central incisor, which has a failed endodontics on it. And the endodontics not only has created an apical lesion, but we've lost all the labial plate as well. I happen to be a big person in the camp of immediate implant placement. Some of you may not feel quite so comfortable or feel that maybe this isn't appropriate, but I've been doing this for probably 15 to 17 years of my career. I feel highly comfortable doing it. So I placed in an implant immediately after decontaminating the lesion. Some of the way that I decontaminate the lesion, I'm a big believer in irrigating these sites with either povidone iodine or metronidazole IV solution. There's a whole host of reasons I don't have enough time to go into up here, but I think that these sites can be quite septic, particularly when they're endodontic failures. The insertion torque was pretty good, 30 Newton centimeters, and the ISQ levels were a little bit lower at 61 buccal palatal, 59 mesiodistal. The site received an allograft of mineralized freeze-dried human bone, and on top of that, a membrane. This happens to be a collagen membrane, and the site was sutured. So this was done during a period when I was looking to see about dips, etc. And I decided to look at 1 month to see what the numbers look like. And you can see that the number at 1 month has dipped down by 10 RFA units in the buccal palatal and 16 units mesiodistally, which is fairly profound. The question is, what will you do? Obviously, you've decided to take this road, so you're going to go at 2 months now and take a look again. Well, it's still not very good. And the question starts creeping into your mind, was I smart in doing this, or should I have waited and grafted the site before? I happen to like placing the implant at the time of extraction because I personally feel that the implant surfaces are far more osteoconductive than most all of the graft materials that we use. So I'd much rather have the implant surface as the scaffold rather than the graft. So we're in trouble at 2 months. At 3 months, now we're starting to see things taking an upswing. 48 in the buccal palatal direction, but mesiodistally, we're back to where we began. I'm getting hope. The nice thing is when the patient says, well, why can't we proceed at 3 months? I say to him, the machine says you heal slowly. The machine says it, not Dr. Rosen, the machine. So I'm no longer the bad guy. By 5 months, I'm back to where I began, at 59/60. And at 6 months, it was pretty much stable. Soft tissue is healed well, and so it was decided to restore this area. This is the outcome at 1 year. Now, the one thing that I hope for in the United States these days is it's a phenomenon known as geographic success. I'm not sure if any of you are familiar, but in the United States, especially if they live in the Northeast, you can have great geographic success. And geographic success is defined by you hope and pray that the patient retires and they move to the warm confines of Florida so that they are no longer your headache. This is geographic success. Unfortunately, I have not achieved that with this patient, but I keep hoping and praying that she will, except with this storm Michael that has just hit. This is another nail in the coffin for people to want to stay up north rather than going down south to Florida or South Carolina because of the bad weather. So some of you out there are saying, Paul, you're wet behind the ears. It was an immediate extraction site. That's the reason why you saw this. It doesn't happen in healed sites. Oh, well, really? Here's another patient, a 54-year-old female with an unremarkable medical history. She comes to me desiring to replace her maxillary second molar. She doesn't like the way the food impacts in this area. So I access the site, I place an implant, good insertion torque, 32 Newton centimeters, good ISQ value, 7170. Suture the area. I feel that this is more than acceptable to have transgingival healing. And I looked, because this was the period I was looking at the bump phenomenon, and this particular electro-wetted implant surface shows pretty good stability at 2 weeks, but with this patient, we can see it dip down a little bit at 2 weeks. And at 4 weeks, it still remains fairly well dipped. But that's more than I typically see with a lot of implants. At 7 weeks, it's still dipped. And according to all the textbooks, by 7 to 8 weeks, we shouldn't be seeing dips still. And dips usually 4 or 5 units. This is 11 units. It's about 13%. That's pretty significant. But the beauty about having Osstell in your armamentarium is that the machine guides you as to when you proceed. It's no longer guesswork. The machine tells you. By 3.5 months, we're up to 6870. So we're able to proceed to completion. And this patient is now 7 years post-op, and you can see this has been stable. Why was RFA so beneficial? This patient's medical history would never have suggested that it would take so long for her to heal. So how do you estimate healing in patients? Especially if they come in a lack of osteopenia, osteoporosis, they've had T-scans, they have no medical indications such as diabetes, thyroid disease, or any other such indication. Yes, they've been through menopause, but that's not enough of a reason. If you would have reverse torqued this early on, maybe you would have reverse torqued it out and destroyed osseointegration occurring. So destructive measures such as reverse torque may not be so advisable. And if you go by the quote-unquote literature, most clinicians, because of these second and third generation implant surfaces, would never have thought that in a placement scenario such as this, that we need to wait 3.5 to 4 months. Now, some of you might say, well, maybe the patient was chewing on this area and that could account for the reason it took so long, but I can assure you this is a very compliant patient and that the waiting period was not affected by her chewing or functioning in any way, shape, or form on this area. So the last patient who I would like to present to you today is one that I say has, quote unquote, extenuating circumstances. And they always say never treat family and friends, and of course, the friends always have the extenuating circumstances, as do family. This happens to be a 51-year-old female, and her chief concern, using the European system number 27, has recently had its endodontics fail. The prognosis for this tooth's combined lesion is hopeless. Now, the implant at 2.6, I had been placed 8 years prior, and the treatment had gone uneventfully. So I knew that this patient historically had reasonably good healing capacity. My problem as of late is that this patient has some very severe gastric issues. And she's dropped 60 pounds in weight over a course of a number of months, which is inappropriate. She was obese, a bit obese, but not morbidly obese. I mean, she's painfully thin at this point. She is, yes, taking Synthroid for hypothyroidism and budesonide for asthma, but nothing else remarkably. I have a big problem with this patient because if I'm going to graft, her gastroenterologist would prefer that I limit any exposure to antibiotics, and pain medications he wants to keep to a minimum, Tylenol at best. So of course, this really makes my job difficult, especially if one is going to do this sequentially with a number of surgeries. I would like to limit her problems to one time, one place. So I decide to take the tooth out, and lo and behold, I'm going through my armamentarium of implants and drills, and I realize quite quickly that the largest size implant, which I have in my armamentarium, which is 6.5 millimeters, is too small for the site. So I decided, since this is a friend and I'm a fool, that we would do something that I've done in a number of circumstances, not for everybody. And I said to Jane, I said, look, we're going to do something that I don't typically do, and it breaks all the rules if you're willing to allow me this. What we are going to do is I'm going to hold the implant up with a college plier, and I'm going to place graft around the implant to stabilize it. And I'm going to put a barrier over this, and we're going to pray, and we're going to hope that this integrates. So many times I've had friends ask, so what was the insertion torque? I said, insertion torque? There is no insertion torque today. We're holding this. There's no insert. Okay, so what's the ISQ? I said, ISQ, are you crazy? If I put the smart peg on, I'm pulling it out. There's no insertion torque. There's no ISQ. There's no brains in my head. What am I doing here today? But she has extenuating circumstances. So Tylenol was all I was relegated to in pain management. And antibiotics, I did as short a course as I could, because it wreaks havoc with her stomach, and she is a nightmare at this point. So this is the way things looked. We'll start at 12 o'clock. That's at 2 months how it looked. To its right at 1 o'clock is 4 months. At about 5 o'clock, you can see how it looks at 6 months, at 8 months, and at 10 months, and in the middle, 13 months. So let's look at the journey along the way. The first reading I took was at 6 months. It was 35/25. The first reaction in my head was, you're an idiot. Why in the hell did you do this? But since we went down this path, we decided we're going to play this out like the fool I am. So I said, okay, we're going to come back at 8 months. And she was wincing. It's in the second molar region. It's difficult to access. At 8 months, we're at 44/50. So I said, we're We're going in the right direction, but we're nowhere near where we're ever going to get. Am I stupid still? I waited for 10 months. Now we're at 58, 56. I think there may be hope. But if anywhere along the way I decided to go forward or reverse torque or do anything blindly, I would have blown this equation. Because it wasn't until 12 months that I got a reasonable reading of 61, 64 based on net or anywhere 59 or better, a chance. But this is low on the ISQ scale. It wasn't until 13 months that I was able to proceed, and I took this patient and I myself provisionalized her with a very minimal contact crown in her hardest centric bite. So I do believe at a certain point we need to stimulate these implants, and I think sometimes we wait so long. The take-home message is the impossible sometimes takes a little bit longer, and it's dispassionate devices such as the Osstell system that enable us to make clinical decisions that might not have been possible to meet patient needs. So to conclude my lecture today, and I don't want to intrude upon my dear colleagues' time, I have a minute and a half. Number one, patients rely upon our judgment to provide them with optimal outcomes. Number two, treatment decisions should be based upon evidence and not inference, whenever and wherever possible. There are over 900 articles on the use of RFA that speak to this. Need I say any more? 900 articles. Are you still waiting for evidence? It's out there. There's plenty of it. Last but not least, Osstell provides us with objective and verifiable data to shepherd our patients through their implant care. And as I often say, patients usually do not read the textbooks that we write about them. They seem to do their own thing. So again, from the bottom of my heart, I want to thank the Osstell company for bringing me back to Vienna. Since 1979, this is my first experience back, and I thank you. I get to practice my Deutsch again. And to all of you, I hope you have a successful Congress. I hope I gave you a little enthusiasm as to, I know I may be just preaching to the choir, but if you don't have an objective means of determining your implant integration, you're way behind the curve. Buy one today. Thank you very much for your time and attention.
Thank you so much, Paul. Thank you.